Thank you, Liz. Thought I hit it off. Okay. I'm just going to tell you about our autism services. So I'm a BCBA and I'm the supervisor of our autism services for the 6 counties. I'm going to share. All right, is that sharing? Okay.
Yep.
Okay, so like Liz said, at CMH for Central Michigan, it's going to be more specific here than it is other places, but we will go through. Let's see. So just a quick touch on autism, that it is a neurological developmental disorder. And the numbers right now are that there's about 1 in 36 children being diagnosed in the US with autism. Even 10 years ago, that was like 1 in 110. So this number keeps going up. And part of that is just the more awareness for that diagnosis. The things that need to be considered when we do the diagnosis is that they have problems with communication, social interaction challenges, and rigid repetitive behavior. And those need to be have always seen some of that, and that it is across different environments. So sometimes when we're doing diagnosis, like things like trauma can kind of look very similar, but our evaluators will be looking to try to make sure, weed it out and make sure that's what's going on. So throughout, so all of the community mental health in Michigan, this is standard that anybody up to age 21 who are Medicaid eligible qualify for autism services. And those autism services are typically applied behavior analysis. We can also do parent caregiver guidance, which I'll talk a little bit more about. And the children are also typically eligible for additional speech, occupational therapy, or physical therapy. Now, like those are services that we don't offer in-house, but it is, again, things that could be offered. So go on. So the process. So if a child has not ever been evaluated for autism and they have the straight Medicaid, they'll come through our same day access, just, typical process. But while they're going through that, they're going to get screened. So there's a couple different parent questionnaires. One's called the SCQ and one is the MCHAT. So we will do a screening, and depending on what that score is, then we go ahead and move them on to where we're going to refer to an evaluator. And so that will be for that comprehensive diagnostic evaluation. That diagnostic evaluation includes an interview, usually about an hour interview with the family to get that history, and then also direct observation and different standard tests that need to be done. And we contract with one provider that does, they have 2 evaluators in Mount Pleasant, but we also have a couple of internal intermittent staff who are psychologists who can do the evaluation. And so typically they are doing them either in Gladwin, Midland, or Reed City. Right now we are looking at usually 2 to 3 months when they get to the evaluation, but we're saying they're completed within 4 to 5 months. So generally they will do that evaluation. Oftentimes parents are told right then and there if the child is going to be eligible for autism services or not. But then the report might take a couple weeks to get through and to kind of process everything. But so we're saying 4 to 5 months, which is much shorter than it was in the past. So now I said that was if they had never been evaluated. If they come in the door and they already have been diagnosed with autism, could have been from an outside provider, some other source, then we ask to have a copy of that report so we can review the report. Okay, my computer keeps saying it's going to restart, so hopefully it doesn't. There, postponed. So we review that report to see if it meets the criteria, because MDHHS requires an evaluation done every 3 years. So we need to make sure that was within the past 3 years, that a qualified person did the evaluation and it just meets all that criteria. If it does, then we can go ahead and move them right into getting services. if they come in with private insurance. So if they come in with private insurance and they have not been evaluated, then we just redirect them because the evaluation needs to be done through their private insurance. Autism services also need to be through their community providers. So if they come in though and they have private insurance, but they have Medicaid as secondary, they already have that qualifying evaluation, and they're already working with a community provider to get ABA that accepts their primary insurance, then we can go ahead and authorize some services for them so that as the secondary source. So there are pieces that we have to go through if they're private insurance. But now, so now back to when we get that evaluation. So we have sent them out, got that evaluation, like I said, within 4 to 5 months. About 75% of those tested meet criteria, a little bit less. And we typically have about 60 consumers in our queue waiting for the evaluation. You know, they've been referred, they're on the list waiting to get evaluated in that 4 to 5 months. So that 60 just has been pretty consistent for a couple of years. And we have about 400 actually active in services. So once they get through, so if they are diagnosed with autism, then we talk to them about those autism service options. So as I mentioned, parent caregiver guidance is something we can do, and we're really encouraging, and I'll talk a little more on that. And then the other piece is that referral to an ABA provider. So like Liz said, we contract with ABA providers, and those they can either provide in-home or in a center. So the family training, this is where we can work with the caregivers, anybody in the family of that diagnosed youth, and we can start providing some services, you know, help them understand autism, understand why there might be the behaviors because of autism, also kind of give them that groundwork of what to expect from ABA. We can start working with them on some safety and crisis planning. So if there are some severe challenging behaviors, we don't want to wait until they get started with ABA. We want to be able to come in and start doing some stuff with the family. We can also be doing some focus interventions where we're teaching the parents how to implement things like toilet training. Maybe they have, the child is picky about their food. Maybe they're running out into unsafe areas. Even starting some of that communication skills, encouraging the family to maybe interact more and develop some play skills. So really some of those skills that we're going to be teaching in the ABA purview with a tech, but we're doing this, having the parents do it so that we can get started right away with that. And I'll explain that a little more in a second. But so those are some of the things we can do with family training. We can also be consulting with schools. And this can happen as often as weekly, might only happen once a month. So we kind of have a variety in there. And this can be done in the homes, it can be done in a CMH office, or it can be done virtually. And so typically this is done by CMH staff. We have 6 behavior analysts on our team besides me. So their big focus now is on getting this, get family training going, working with the families immediately while they're waiting for one of the other providers. We also have a few providers that will do family training immediately. So we're having more and more where we can get this started. Okay, so I keep mentioning ABA providers. So we contract with about 25 providers across the 6-county region. So these are private agencies that provide ABA. So you can see some are in center, that's the lighter color there, and some are in-home providers. We have more in-home providers, but we actually have about 67% of the consumers are being seen in centers. And I think because it's more, you can get more in there at the same time. So we have centers in Clare and Isabella, Midland, and Gladwin. Clare and Gladwin each have one. Isabella and Midland have a little bit more. Macassa and Osceola at this point don't have any centers, but we have providers, and some of those in-home are overlapping in different counties. Let's see, oops. There we go. Okay, so I've mentioned applied behavior analysis, and like I said, it's either in a center or at home. Occasionally, we will have ABA where we're doing stuff in the community too. So that's why I say usually. Oftentimes it is anywhere from 10 to 30 hours a week with a behavior tech. So this is the other service in addition to that family training that I talked about. So a behavior tech is they have gone through some training, but limited training. But they're the ones that are working directly with the consumer that all those hours throughout the week. Then a behavior analyst who must be at least a master's level, they are supervising that tech. So at least 10% of that time is supervised by a behavior analyst. So that would be the BCBA. The number of hours, we must have medical necessity for the number of hours. So, you know, I mentioned in here 10 to 30 hours is common. It can be effective with less. We've definitely seen, especially older consumers, you know, in that teenage range, maybe 2 to 4 hours a week can be effective. Just parent training can be effective. Now, I have the caveat though that some providers will require at least 10 hours per week in order to accept that referral. So that is a piece, but because we have 25 providers, we're usually able to find one that will meet the needs because again, we're very person-centered. So first thing that will happen then after they've been referred to a provider is that behavior analyst begins with an assessment, which needs to be redone, updated every 6 months. So that assessment is going to be looking at their current skill level and setting those goals of what we're going to work on and, you know, try to develop skills. The wait, there is a wait. So treatment for daytime consumers might start within 4 weeks. But school age consumers are often waiting at least 6 months, sometimes even more than a year to get that direct ABA with a tech. So this is one of the reasons why we have really amped up that family training as soon as they're getting approved, that we are trying to work with them and, you know, develop some of those skills. Capacity. So again, I mentioned that after school time, children can't miss school for ABA. So that's why we have about 75% of our consumers are of school age. They're waiting a long time because most ABA providers are at capacity for that after school time. So those wait lists, like I said, might be 6 to 10 months, could be even longer. And we are encouraging parents to begin with family guidance training. We've had a lot of success with it and a lot of good response from the families with that. So our overall goal of treatment is to help them develop the skills. Obviously, we want to help them develop independence. So autism doesn't get cured, but we're trying to help both the consumer and the parent help them so that they can become more independent. So as we're seeing those goals are getting mastered, we're transitioning to less restrictive services. So that could be less hours of direct ABA, reducing, and then we're fading it out. We might shift to only parent training before closing, and then just helping them transition to whatever their other service, you know, what other less restrictive services could be going on. I think that was it. So, oops, my computer again. Here, I'm gonna stop sharing. Any questions?
Someone in the chat asked if you'd be willing to share that PowerPoint.
Oh, of course, yes. Yep, I can, I'll drop it in the chat. So, and I want to throw in though too, since I have a moment still, that, you know, I know you're going to be assessing and seeing maybe really challenging cases. If it's like this family needs some help immediately, that is things where, like I said, our BCBAs can get in there and get working on like some of that crisis planning, helping the families understand things that maybe they can change right away, even before ABA actually starts. So I'm, you know, if we can be encouraging families to participate in that and the foster care families as well, getting them, helping them see that that's a good opportunity right from the start, I think that helps. So I see a hand up. Did you have a question?
Yeah, just a quick question. You talked about the BCBAs, which I think is Really good. Is that after they're off the wait list that sits around 60, or is that something that comes before that?
That is after the 60. So that wait list of 60 is that evaluation to see if they meet criteria to diagnose them with autism. So that's done by a psychologist. And then they get transferred over to the piece where we can start family training, and that's where they might be waiting for a BCBA at a provider for 6 months, another 6 months. But we can at least be doing that parent training immediately there.
The other thing too is the other thing is if they meet criteria for some of our other services, they'll get home based during this time period before that evaluation is done, or outpatient therapy. And so they're actively getting services until that full autism evaluation happens. We set them up with case management or home based or outpatient. So I just want to make sure that you guys
Good
heard
point,
that
Liz.
too.
Thanks.
Yeah.
Yeah.
They're not just sitting there.
Right. Anything else?
Someone asked, is there a new program offering overnight safety, CLS, respite? We do have someone talking about respite and CLS later, but Mary, if you want to answer that, you can, or we can wait for Angela.
Yeah, I don't really know on that. So it's not connected with us.
We can answer that later, Lori. Angela will be here talking about CLS and respite. And we can ask her that question. Any other questions? Or Kevin, sorry if I interrupted you. Did you have a clarifying question to ask?
No, I'm all set. Thank you.
All right. You need anything else then? Liz, do you have any additional comments that you would like me to make?
No, thank you so much for coming today. I appreciate it, Mary.
You're welcome. Yes, and I will drop this in the chat. So thanks.
Thank
Yeah,
you.
thanks, guys. Bye. Yep.
Our next speaker is Christian. He is our crisis supervisor over our 6-county area, and he is going to be talking about crisis services that we offer children and youth.
Hello, everybody. 44 people. Wow. Definitely more than I was planning for. So I guess I better get my stuff together, huh? So good morning, everybody. I'm going to share my screen real quick. Can everybody see my PowerPoint? Okay. Nothing super fancy. My understanding is that we want to kind of go over like broad strokes of the programs, and just so you have a better orientation as to what crisis services look like within our 6-county catchment area. So at the end, we'll have time to ask any specific questions, scenarios, anything like that that you want to run through, and we'll go from there. I could speak on this topic for a long time, so I'll just try to keep it short. So who are we? So as a crisis team, we are a centralized program, meaning that you might be in Osceola County, you might be in Mecosta County, but as a crisis service, we operate out of all 6 counties. So let's say that you're in Mecosta County and you're calling, asking to talk to a crisis worker. You would be potentially talking to somebody over as far as Gladwin County, Midland County, but we all operate the same way. Our policies and procedures are all the same. The interaction, the perspective, the tools that we use to measure risk and to make referrals to outside resources, it's all going to be the same. So just kind of that brief overview. Conversation today is going to be crisis services. We'll define what Crisis Mobile Intervention Team, CMIT, which is my team, and then Children's Mobile Crisis Team, CCMT, is which we call it here internally. But you guys at DHHS may have heard of it as ICCS, or Intensive Children's Crisis Stabilization. I've heard that term kind of used a lot more at the state level. And then when you start to trickle down to the individual CMHs, they kind of talk about it a little bit differently, or maybe they've named it something different. So just know that crisis services, it's all going to be under the same program, my program here at Central Michigan CMH. So if you ask for crisis services, you'll get the same individuals. I know that in the past, when we've had conversations with DHHS before, or really any other outside agency, is that they feel like there's a terminology or a phrase or something that they need to ask for specifically in order to get the thing that they're looking for. I just want to assure you that that's not the case. If you call and you say, hey, I'm a foster care worker, hey, I work at DHHS, I've got a family that I'm working with, this is what I've got going on, they'll probably route you to crisis if you don't already ask for the crisis team, and then we'll be able to answer any questions from there. Continuing along, children's mobile specifically, who are we seeing? Who are we serving? Individuals from birth all the way up to 21. That's a little bit outside of some of your ranges, but with extended voluntary foster care, we might have some overlap there. What are we doing when they're seeing them? We have two clinicians. So when we receive a children's mobile request and we determine through our kind of screen out process if they're eligible for that service, if it's appropriate for us to go out, then we are going to respond with two clinical staff. At least one of those individuals is going to be a mastered prepared clinician. The other individual is going to have, if that mastered prepared clinician isn't a children's expert themselves already, we're going to have another children's expert there. The two staff consist of a child-specific expert and then one crisis staff. So you're going to have somebody from the CMIT level. So you're going to have kind of the blended. The idea behind there is that you're going to have a blending of somebody who really knows families, systems, children's interventions, and then you're going to have somebody that really knows crisis interventions, de-escalations, and they kind of play off of each other. So the idea being that if you kind of go into a situation and things are escalated emotionally, we're going to be able to deal with the emotional side, and then if things are starting to route towards maybe we need to be looking at hospitalization, you're going to have the other side of that coin and then kind of pass off each other as it comes up and kind of play off of each other. What are we doing when we're seeing them? We're providing de-escalation, crisis intervention, whether that looks like providing skills to the parents, providing skills to the children, giving them direction, advice, maybe linking them to other additional services, whether that's the outpatient side, inpatient side, residential. We'll talk a little bit more about the continuum of care later on in the presentation. But ultimately, we're kind of saying, hey, what's happening with this family right now, and how are we going to provide a meaningful intervention that's going to be able to stabilize this family now? When are we seeing individuals? So every CMH is a little bit different throughout the state and how they operate this. As far as Central Michigan CMH goes, we operate Monday through Friday, 8 o'clock in the morning until 10 p.m. in the evening. That does include agency observed holidays. So let's say we have Christmas Eve that happens to fall in the middle of the week. We do have children's mobile available during that time frame. Where are we seeing individuals? In their homes. After a screening for safety. So, as you guys are aware, coming to the office is kind of like our territory. We're there, we know what's happening. Going out to the home, as you guys are also aware, is a variable mix of safety and danger. So we do have a screening process in place that includes things like, who's in the home actively? Are there firearms in the home? Are those firearms secure? Are there animals in the home? Are there aggressive people, adults or children, in the home? Things like medical needs. If there was an overdose, that's something that we would also roll out, because at that point we really need to be looking at medical attention first before we're problem solving what's going on. Are there things like physical aggression that are happening between the child or an adult? Similar to you guys, we're not going to put hands on individuals. We're not going to physically intervene, so that really that's more of a law enforcement thing there. And so we're kind of assessing the situation when we take that initial phone call to determine who's the appropriate place for this to go to, whether it's us going out, routing them to the emergency department, saying, hey, you should really call law enforcement to intervene physically, or maybe it's stable enough at this point, you should come into the office. Maybe telehealth is an option. Within this, we also have 2 hours. All of our areas are considered to be rural areas, which means that we have 2 hours from the time of request to physically be there in person. And what we've noticed, and this is why, I think that our children's mobile team isn't as utilized, is because oftentimes when families are calling us, we're saying, yep, this is actually appropriate. We'll be able to roll out there. We get a hold of the secondary clinician. We get an ETA. We talk to the parents and say, hey, we're about an hour out. And they say, what do you mean an hour out? That's way too much. I need something now. And so then based on that, we might pull back the children's mobile response to be able to then We want to pull back the children's mobile request in favor of something more immediate, like a telehealth response, or maybe the parent says that's not soon enough, I need somebody here now, and then they opt to call law enforcement or take them to the emergency room. So there are different things kind of at play there that you should be aware of. And then why are we seeing the individuals? Again, to support them, to support the families. I mean, similar to you guys' mission, we know that families can thrive together with the proper services and supports in place. And that's our ultimate goal, to provide that additional service and support. Crisis Mobile Stabilization Intervention Team, CMIT. We are a 24/7 service. What do? We provide unscheduled services aimed at reducing or eliminating the impact of unexpected events on the mental health and well-being of an individual or a family dynamic. So this is not a team that we would go out to somebody's home. This is more so for kind of evaluating the acute situation that's happening, whether they call us, they come to the office, or they present in the emergency department. Who do we see? Really anybody, if they show up to our doorstep or they call us. There are some exceptions. Like I said, that there are some exceptions to that rule. If they go to the emergency department and they have, like a private insurance as a primary, whether it's a Medicare, Blue Cross Blue Shield, tribal insurance, anything like that, we are not the funders. We're not the kind of the pre-authorizers of those insurance providers. So we don't get involved in that. But if they show up to our doorstep, or the family calls us, the individual calls us, we will see them from start to finish, regardless of insurance status. We will, we've had plenty of situations where somebody shows up to our door. We say, yep, hospitalization is absolutely appropriate, but you have Blue Cross Blue Shield. We will take you to the emergency department. We'll get you to the emergency department. We'll fill out all the documentation. We'll call the hospitals for that person, and then get them connected to where they need to go. And then from there, we'll let the rest of the system kind of do what it's supposed to do, because there are systems in place for those individuals already. But we believe in continuity of care. We want to make sure that individuals are getting the appropriate services. So what are we doing when they're seeing them? Some of that has to do with the environment that they're at. So if they're at home, our intervention might be a little bit different than an emergency department or our office. Again, the intervention might be a little bit different. But at all points of contact, we are evaluating for the appropriate level of care. And so again, kind of going back to the idea of terminology, or asking or saying a specific phrase to get a desired response, it's not necessary. We've had plenty of situations where a person says, hey, I want to go to a psychiatric hospital, and then we evaluate them for that. And we've had plenty of situations where somebody has no mention or desire going to a psychiatric hospital, and based on certain risk factors, things that they've said, pulling things out during that intervention, that we said, you know what, you're actually really high risk. We would actually feel more comfortable putting you in a psychiatric hospital, and everywhere in between in there. So I just want to impress upon the fact that you don't have to say anything special for us to be considering that. We should be considering that at every contact that we have with an individual, because we're always looking at risk levels. We're always looking at what's happening, the context, and plugging people into the appropriate level of care. When is the crisis, the CMIT team meeting individuals or seeing individuals? It's 24/7, 365. This is a state mandated program. We have to be here at all times to provide crisis emergency services. We operate a crisis phone line similar to 988 before 988 was a thing, where individuals call the local CMH office 24 hours a day, 7 days a week, asked to talk to a crisis person, and they will be connected to a crisis person. And then we'll kind of do our thing from there. If you call the local office during business hours, you'll get one of our reception staff, and they'll say, and you just let them know that you want to talk to a person with crisis, and they'll forward your call along. If you call after hours on a weekend or a holiday, those phone calls automatically get forwarded to our listening service called Listening Ear, based out of Mount Pleasant. They are mental health technicians, meaning that they're trained in crisis response, but they're not like degreed individuals, kind of like our crisis team is. And so if you want to talk to them, or if you have information pertinent or questions pertinent to the CMH role of things, you just have to ask for a crisis member. They'll take some information, and then we'll return your phone call. It doesn't usually take more than about 5, 10, 15 minutes for us to return that phone call, depending on what's going on. Where are we seeing individuals? How are we providing the service? Whether it's face-to-face in the office, going out to the emergency department, telehealth. Since COVID, telehealth has been, very, very helpful to be able to respond to things faster, and phone contacts. really everywhere and in between. We try to meet individuals the best that we can. We are not set up for like email correspondence or text correspondence. I know that some individuals would like that. We simply don't have the technology capable in order to provide a response. What we don't want to happen is somebody to text us or email us and say, hey, I've got this acute situation, and that person not be working, right? And that would be terrible for somebody to ask for help, and then perceivably nobody's there to help them because it went to somebody who's not working. So that's why we don't have that system set up at this point. Why are we seeing individuals? Again, to reduce the crises and triage individuals. Again, we know that individuals don't always know what resources there are available. Professionals don't always know what resources are available. That's why we have meetings like this. And so, again, that's why we operate with the idea that we're just going to be assessing consistently, because you may not know what is out there that you might be appropriate for, or the individual might be appropriate for. So we're just going to, take the information that's there and provide the services that are most appropriate and offer them. So going back to like, what are we assessing for? Again, we're assessing for levels of care for individuals, and that includes something all the way up to like Walter Reuther state hospitalization, to a mental health unit, crisis residential, partial hospitalization, 42nd court crisis respite for adolescents. So like a respite placement. There are very specific criteria where a respite placement would be utilized, but it is within our repertoire to be able to utilize that. Safety planning, so developing a safety plan with a family, similar to what you guys are offering families in the CPS realm, to then connect them to ongoing outpatient services, connecting them to same-day access, crisis walk-in clinic or crisis clinic. That's typically for my adults, but I can kind of front load individuals to see a psychiatrist in some situations. Well checks are us taking a proactive approach to individuals that we consider to be higher risk, where we're reaching out to them and providing additional services, just kind of saying, hey, how are you doing? What's going on? Has anything changed? Has it gotten better? Has it gotten worse? Have new needs been identified? Have we identified new needs? And then just kind of working with them on a little bit more of an intensive basis in a short term. CSSRS appointments. So if individuals are connected to outpatient services and because they've scored moderate or higher in their CSSRS scale, case holders will have what we call CSSRS appointments in their schedule, just so that somebody who's a part of their treatment team can then be connected to see a clinician a little bit faster. So again, kind of wrapping around the individual, providing additional supports to be able to help alleviate whatever crisis or maybe prevent crisis from occurring. And then additional resources with like food pantries, housing resource, sort of Social Security. We have benefits eligibility specialists, which I'm sure you'll hear more about later on. But just these individuals that can get kiddos or adults into additional ancillary services that are maybe not internal, but maybe external, to be able to help stabilize that family situation. From our perspective, it's very difficult to work with families that are not getting their basic needs met. So if you go back to Psychology 101 and Maslow's hierarchy, right, it's hard to start working on these more difficult conceptualizations of mental health and trauma and generational trauma when you're not able to put food on the table, you're not able to eat, you don't have safety and shelter over your head. So that's all stuff that we take into consideration when we're developing safety plans and then trying to get the family stable. So let's say an individual does go to a hospital, whether it's a psychiatric hospital, partial hospitalization, crisis residential placement. If they are not already connected to a treatment team, we have a hospital liaison or a discharge planner who will help kind of bridge that gap. So that individual will follow that individual or that family from the discharge all the way to getting connected to outpatient services, which would include things like getting connected to a case manager, outpatient therapist, psychiatry appointment, additional well checks and supports from CMIT, other ancillary programs, things like that. We have a requirement at the state level that once an individual discharges from that level of care, because of their risk level, we have to see them within 7 days. That's a state mandate. Internally at CMHCM, we strive for, it's a policy for 3 days. We strive for 2 days. And typically we're hitting that pretty well. Obviously, there are other factors outside of that. People have other appointments, they have preferences, weekends are a thing, but we very much will hit that 7 day requirement at the very least. Again, CSSRS appointments, well checks, medication management, all these things are things that we are looking at and putting in place, whether it's the ongoing treatment team that's already established or the hospital discharge planner. So, I mean, we have quite robust services to help, kind of ease people from that higher level of care back into community-based services, because we do statistically recognize that that's a very high risk time frame in an individual's life. And so we want to try to cover them as best that we can. So super broad overstroke or overstrokes about crisis services, kind of naming a couple of definitions, levels of care, things like that. It's a very small time frame, but I want to kind of open up to questions here if there's anything that you want to know specifically about in there. Anything? I'll put my my contact information right there. If you guys are like me and these questions don't come up, or maybe you just don't want to ask something in front of a room of 49 now people, I get that. So there's my email address, my cell phone number. If you have questions, comments, concerns, situations that you want to run through, obviously HIPAA, mental health code are a thing. I might not be able to discuss specific situations with you, but we can run through scenarios. We can talk about general practice, maybe a rationale for, why something happened or maybe something didn't happen, whatever. I'm willing to have those conversations and answer those questions. You're welcome to call the office as well and ask to talk to the crisis supervisor. I'm the only one of me, so that call will get routed to me without a problem if you don't take down my information now.
Can you share, Chris, a little bit about in the past we had 4 different providers for crisis residential for children, and then we also had the state hospital. The state hospital is going through renovations now, but how many children crisis residentials do we currently contract with?
So we currently contract with 3 children's crisis residentials. There were several. There was one up in, what was it called? Rose something or another, somewhere up northeast. They closed down. There was a couple of other ones that have closed down over the years. But yeah, we have currently 3. 2 different providers. One has 2 locations.
Are they in Detroit and Grand Rapids?
One is in Lansing, one is in Detroit, and yeah, the other one's in GR, I believe.
Okay. I think some of the frustration sometimes is when they have a foster child that might require a higher level, either residential or hospitalization or something else, and it's just I think frustration across the board that a lot of our resources have continued to decrease as the years have gone by, where in the past we had a lot of options for people for diversions and a lot of options for children. Yeah, so I thought it'd be helpful to kind of share.
Yeah, no, for sure. I think, what was it, about 2 or 3 years ago, we had 5 or 6 crisis residentials at one given point, and now that number's cut in half. So I mean, a pretty drastic change. We do have psychiatric hospitals that we have contracts with throughout the state. There's Helen DeVos opened up a med psych unit for kiddos in Grand Rapids. That's for individuals that have co-occurring medical concerns along with psychiatric concerns. So that's relatively new within the past couple of years. Well, actually within the last year. I think they haven't even hit a year yet. Yeah. There's been I think a bigger push to provide more services in the school and things like that than there have been of maybe like facility settings. I know that Hawthorne is no longer, and because they're going through reservations or renovations, all those kids are being routed to Walter Reuther. And then my understanding is that they're probably at capacity at Walter Reuther at this point. And so yeah, and it feels like a lot of those children's resources are definitely starting to dwindle down a little bit.
Thank you. The other just resource I wanted to mention too is Pine Rest has a, mother baby program. It's a partial hospitalization, so the folks are there from like 9 a.m. to like 4 p.m. But they have a entire team that wraps around women that just gave birth that have postpartum depression or postpartum psychosis that they don't the mom doesn't need inpatient but does need some assistance. There is a partial. The problem with it being in Pine Rest is it's in Grand Rapids, so it's hard for our local area to get down there every day. And so usually we talk to churches about providing hospitalization, but it's a really great program that has a psychiatrist that is able to, prescribe medications for women that just gave birth. You're able to take your baby with you, and they have the entire unit is set up like a living room. And so it's a really great option for mothers that just gave birth that really need additional assistance too. Um, yeah.
Yeah, definitely. I love that program. It's one of 6 in the whole country that focuses on the connection between a child and their mother. I've heard it described as as infant mental health on crack, just because it's so intensive and it's so focused on essentially prevention. And I think that's one of our very few really levels of care that are beyond outpatient, that are going to focus so much on prevention, family structures, and stabilizing and giving resources and skills to new mothers who might not have it for whatever reason. Actually, we just made 2 referrals over to that program. And actually both situations where CMIT consulted with me and they said, hey, I've got this mom who just wants intensive services, and they have a 6-month-old baby, and I think there's like a 2-year-old at home too. And they called and said, hey, what about mother and baby? Here's the brochure. Go talk to mom about it, get some information. And again, mom had no idea that program existed. And we offered it and they accepted. Transportation was an issue. This is a Midland family. And we were able to provide gas cards at least half the time to be able to get that family down there to get connected and to really provide some additional preventative supports and services. So
That's awesome.
Yeah, not trying to stroke our ego or anything, but just again, it's one of those situations where we've seen a need and we know we're offering services that would meet that level of care and help for that family.
And for the children mobile crisis team, like sometimes because of the time frame to get out to the home, that might deter some families.
Mhm.
Is there any other reason why you might not go out to a home if a family calls and requests the mobile team? Is there any other times where
Yeah.
um,
So like I was saying, we have a list of kind of rule out, rule in questionnaires that we go through with families. It's kind of like almost a checklist type thing, where if a family is, either the family themselves are requesting Children's Mobile to come out, or maybe even an outside provider, or we take a phone call and we're starting to consider it ourselves to offer that as an option for a family. We then start going through this list of questionnaires. A lot of it has more to do with medical stability, physical aggression, firearms in the home, and animals, maybe aggressive animals, and just kind of asking some of those questions. Those are big situations. I think the more often scenario that we get is that there's some sort of laceration, maybe some sort of an ingestion of medication, and that's an automatic rule out. We're not medical personnel. We certainly don't want to say, you're bleeding actively, wait 2 hours for us to come to your home. No, that needs to be treated medically before we're providing any sort of mental health interventions. And so we would route that family over to the emergency department. Same thing with physical aggression. I can remember there's a couple of times where there was a kiddo up on a roof somewhere, and it's like, we're not going to be able to climb up the roof and get the kiddo down. That's a dangerous situation. We're not going to say, yeah, wait for us up there for 2 hours while we come out to your home. That's definitely more of an immediate action necessary. So we routed them to law enforcement. I think ideally, actually, in hindsight, I think I should have showed the crisis kind of continuum or the flow there. Ideally, the best intervention point is when we start to identify that it's starting to escalate. Unfortunately, oftentimes when and this is just anecdotal to my own experience here, is that normally we get those phone calls when we're kind of at the top or nearing the top of that crisis, that kind of crisis escalation model there. And by that time, often, one, our response time is too long. Nobody gives us lights and sirens to be able to respond. We can't go 90 miles an hour down the road to get to a family's home. And so like either there's a time constraint or things are so physically escalated that for us providing an intervention is not going to be helpful at that point. So ideally, if you're talking to families about utilization of children's mobile crisis, it would be that we identify that there's a trigger, and as it starts to kind of come up that kind of a bell curve, right? As it starts to come up, that's the ideal time to call us, and we can put interventions in place. We can go out to the home before it gets to now we're yelling, throwing, breaking things, and things have escalated so much. Hope that makes sense.
Yeah. Yeah, you guys definitely, well, and you guys want to identify families that really need it and kind of wrap around them so that, yeah, that it doesn't escalate and that they call way ahead of time.
Mm-hmm.
Any other
Do we have
questions
anybody
for?
from, I had one more thing. I just realized that, is there anybody from Clare or Gladwin counties in this meeting?
I think they're from all the counties.
Yeah, I'm
Okay.
from Claire.
Yeah, we're here, Chris. From
Oh, perfect.
Gladwin.
Okay. So unique to Clare and Gladwin County, we have a program called Family Stabilization Specialists, or FSS. And that is a program that we received grant funding for a couple of years ago to kind of try to bridge the gap a little bit more. And we've utilized that program kind of almost in lieu of children's mobile, because again, we've figured out that by the time that we're getting these children's mobile requests, that they're beyond the point that we're able to respond effectively, efficiently, and safely. And so family stabilization specialists really focused on prevention and postvention in the crisis model. So if they're receiving referrals from the community, whether it's law enforcement, whether it's a school, a DHHS, we've made that model the threshold for referral really low. We've just said, hey, this is an email, this is a phone number, call and give us some really basic information and confirm that the parent is okay, the parent or guardian is okay with us reaching out, and then we'll get involved and we'll identify needs. They have a tablet so that they can physically go out to the home, sit down with the family, say, here's a tablet, here's same day access, you do this, we're going to sit here and hold your hand through services, and we're also going to eavesdrop. And so if you say you have food insecurity, clothing insecurity, financial insecurities, we're also simultaneously going to be connecting you to additional outside resources. And then we also use them for a postvention. So let's say they were recently seen by a CMIT, they were either hospitalized, diverted home, whatever, anywhere in between. And we say, hey, this family really needs to be wrapped around additionally, more than what my crisis team can really handle. They will go out to the home, provide additional face-to-face meetings, provide psychoeducation, they'll provide resources. So again, kind of saying, this is your safety plan that you developed in the moment. Now let's look at this again. What is working? What's not working? Here's some interventions that we've used with families to engage with kiddos. These are all the things that we've done. And then just really kind of lay it on thick. I mean, they can do a lot of intervention. There's no time frame for their program. It's more of an at need. It's a very, very loosely ran, provide the need that's their program. Hopefully it'll get picked up and we'll be able to spread it across the rest of our 6 counties. But currently it's Clare and Gladwin. Alrighty. Thanks for everybody for having me. Again, if you guys have any questions, I love talking about this stuff. I thought I would hate crisis. I fought it as an internship, and here I am. I'm loving it. So and just feel free to give me a call. I have no problem talking out scenarios, situations, and figuring out what makes sense to help our people.
Thanks so much, Christian. I appreciate it.
Yep. Have a great day, everybody. Bye-bye.
All right. The next person is Stephanie Hoffman. She is a supervisor out of our Isabella office, but she's also the SED waiver lead for our 6 county area, and kind of a subject matter expert in a lot of great services that we provide at CMH. So today she's going to talk a little bit about home-based SED waiver and also the new kind of wraparound program. So welcome, Stephanie. Thank you for coming.
Hi, good morning. Happy Friday. So I'd like everyone to lower their expectations slightly when you hear subject matter expert. That's very CMH thing. That's, you're voluntold to be the point person on that. So I'm going to share a presentation, but I would very much welcome any questions, comments throughout this. I tend to ramble, so I'm going to try to rein it in slightly on this Friday morning. So bear with me as I pull up my screen. All right, can you guys see that? Liz, are you okay? Got it. All right, so these are the 3 areas I'll go over today. I am a clinical supervisor in Isabella County. I supervise our children's home-based programs. So home-based therapy, home-based case management, parent support, wraparound, youth intervention. We have many different children's positions. So they're very similar in each of our counties, depending on staffing. So the couple that I'm going to go over today are based on some of the services that would come out of our MichiKANS assessment. So this is just a quick shot of what we would see on our end after MichiKANS is completed. This was a recent youth that came in, and these were the services that are recommended based on that. We'll talk a little bit about family choice. Obviously, all of our services are voluntary. So even if these are recommended services, families do have the option to decline the service, request a lesser intensive service. If that is the case out of intake, we still will continue to have conversations with families about eligible services once they're in the door. So we'll talk a little bit more about some of these. So our home-based services, there's a wide array. So when I say home-based, it's really at home and community-based. I believe Renee talked with you guys this morning about infant mental health. You'll hear from our MST supervisor, Ashley. And a little later today, you'll hear more about parent support partner. So I'm going to focus on our home-based case management and therapy services. So our home-based case management is available in some of our counties, again, dependent on staffing and positions, but Isabella, Claire Gladwin have home-based case management. It's a newer position within the last couple of years. Home-based case management is more of an intensive case management. So it's under the umbrella of home-based therapy, and it allows for that home-based case manager to either have a family they're working with solely for that intensive case management or add on with a therapist to help with those intensive case management needs. So we follow the guidelines of home-based therapy, which is the 4 to 8 hours per month, and that's based on the Medicaid manual. A big part of this is linking families with additional services, meeting those basic needs that sometimes prevent families from being in the place to focus on the therapy aspect. So at least in Isabella, we look at home-based case management more as like a short term, get in, help, with these intensive needs so that then the therapist can really focus on more of the treatment approach with the family. So our home-based therapy program is provided in the home, in the community. It's really an eclectic approach to therapy, meeting the family where they are at. Many of the therapists are meeting with kids at school, going into the home, maybe meeting the family in the community. Typically, home base is what we call as a bundled service. So that means the therapist is doing the therapy aspect, but also incorporating case management needs. I jumped on a little bit early and I heard Chris say something about, it's hard to, address some of the therapeutic needs when, the electricity is turned off. So having this approach is really kind of, again, meeting the family where they're at, addressing those basic needs so that we can get to the point where we're doing some interventions. Many of you on this call may have worked with a home-based clinician. We do a lot of coordinating with other agencies or services that are working with these families. So, we're attending those FTM meetings, school IEP meetings, meeting with probation, attending court appointments with the youth. A lot of our therapeutic approach is based in the family aspect, and I'll talk a little bit more about that, but looking at what do the caregivers need? Often we hear that families are, or parents or caregivers, want to have the child in individual therapy. And, there's nothing wrong with that, if that's what they're wanting. But at CMH, we're really focusing on that family aspect. So working with the caregivers on parenting skills, maybe their own past trauma and how that's impacting them as parents. Something as simple as how to give a direction to a child. What is their interaction like? Another evidence-based we look at in home-based is trauma-focused therapy. So working with the youth, processing their identified trauma, but also providing that education to that caregiver on how to support that child throughout the process, and maybe identifying, triggers or common reactions to trauma. The home-based therapist is able to add on additional services such as parent support, wraparound, respite, CLF, in addition to any other services that we might have available, such as group therapy, linking to even community events that might be beneficial for the family. So I'm going to keep rolling unless I hear, and if you have questions, I can't see the chat at this point. So please just yell at me, unmute and yell. So I wanted to take a couple minutes and just talk a little bit more about the family therapy aspect, because we get a lot of questions on this, from providers or schools. But our philosophy at CMH is really to focus on the entire environment. So this would even be at our outpatient level where they're coming into the office. We really are focused on that family piece. So the therapist is working with everyone, and that includes the caregivers. I can't stress this enough, especially at that early stages of making referrals or even, completing the MichiCans, talking with families about services. This is a really big piece of it. We're not in, the kind of space to just work with the kid and then send them home, because we know that's not the best approach. We need that caregiver's buy-in to. So every family that comes into services, we are structuring their services based on their needs. So looking at that idea of like family centered. So this is something that sometimes happens with, providers or primary cares or schools making referrals, identifying kind of what they think needs to be worked on versus what the family would like to work on. And we always start where the family is at. We want their buy-in. So we're gonna get our foot in the door and then kind of expand from there. Being in the home, working with the entire family, it really provides an opportunity for the clinician, the therapist, to teach skills and then to be able to practice those in session. So it might be, kind of going through the process of a parent giving their child directions on how to do what we would look at as maybe a simple task like clean their room, but that's really difficult for that child to comprehend. So how can that family break it down? How can the caregiver explain things? Along with positive reinforcement, being able to give praise. So that's again why we really want to take the opportunity to work with everyone. Now in home base, that can look a little bit different. We are doing intensive services, so we might have a session that's just with the caregivers, and then the therapist is going to meet with the child at school. So there is some flexibility in how they're scheduling, but our goal is at least a couple times a month to be able to do those family sessions. And then I think someone a little later today is going to be going over evidence-based practices. So I'm not going to touch on that too much, but within all of our programs, we do really focus on evidence-based trainings, meaning these are therapeutic approaches that have been researched and really have been found to be successful. So anything from, like I mentioned, the trauma focus, CBT, to PMTO, which is a parent training, brief strategic family therapy. So we have lots of acronyms within CMH. So you might see that on progress notes or things that you guys might get on your end. So feel free to always ask us for clarification on that. All right, so next I'm going to just touch on wraparound. Many of you or some of you may have been involved in wraparound meetings or at least heard of wraparound before. The state is making some changes with wraparound. So I'm going to preface this by saying I'm going to give you the information that we have up until this point. There were some changes that were implemented that were taking effect October 1st. That got pushed back a little bit to the beginning of this month. So for the most part, we have an idea of what this looks like now. And really it's just more on the CMH end of how we're billing and things like that. The structure is still the same. So wraparound is now going to be referred to as ICCW, which is Intensive Care Coordination with Wraparound. It is the same process. It allows for that wraparound facilitator to do a little bit more of the case management aspect that really we weren't able to do before. So wraparound was really kind of more of like that neutral facilitator, bringing everyone together. Now this allows for that facilitator to work a little bit more with the family on some of the needs that may be there. There's a lot of words on this slide, so I'm not going to go through all of it. I absolutely can send this presentation out. I can send it to Liz to send out. This is right out of our Medicaid manual. So really what we're looking at in terms of wraparound, so ICCW, it's still referred to wraparound in the Michigans at this point, but we are able to provide this service to children, youth, or young adults up to age 21. And they have to have an SED diagnosis, that serious emotional disturbance, serious mental illness, so SMI for our more adult population, or an intellectual developmental disability. So right there, that's any of the youth that we have open to CMH. They have to have a diagnosis coming into our service. We're looking at youth that have complex behavioral needs, and that they have an identified community. What that means is they that youth is placed in a community, foster care setting, biological home, family home. So we are able to provide this service to a youth that is transitioning out of a hospital setting or an inpatient setting. But we also have to know that they're coming into a community setting, if that makes sense. The other part of the criteria for wraparound is looking at two or more of the below criteria. So this really hasn't changed. We're looking at youth that may be at risk of being in and out of home placement, involved in additional services, such as, probation, maybe having foster care case or CPS. Maybe there's some difficulties at school. So we're kind of managing some school behaviors or additional supports are needed. We're also looking at have they received other services before, and a higher intensity is required. So we don't automatically jump to wraparound. We can if that's the need, but we really are looking at, have we had lesser intensive services before? Does the family need additional supports? And we're really focusing on that they have a functional impairment. So again, kind of going into that additional services. Are they struggling in an area of school, home, or the community? Any questions on that before I move forward? I know it's a lot, but. Okay. So if you've worked with these programs before, prior to the changes at the state, in order for a youth to be on the SED waiver, wraparound was a requirement of that. So the SED waiver is the next area I'll talk about a little bit. We still want wraparound to be part of the SED waiver. So you see here, ICCW is recommended to support the child, youth, or young adult and their family through the planning process. What the state is now giving guidance is that in order to be on the SED waiver, wraparound is not required at this point, but it's absolutely recommended. So our process in terms of SED waiver cases and applying for that at this point is to still have the wraparound facilitator or ICCW staff complete that referral. If that family is choosing not to continue with wraparound, or maybe they've had wraparound before and they feel that they're confident in linking to their supports, they can choose to have targeted case management instead of wraparound. But again, at intake, starting the process for SED waiver, we are having that family at least go through that initial process with the wraparound staff. They're the ones that are trained in SED waiver and are familiar with that process. If at any time wraparound is not recommended based upon the MichiCans, we absolutely can still provide that service. So that is common for a youth to come into services and maybe a lower level of care is recommended. We can always provide these services to families based on the medical necessity that was in the previous slide. So, they're having difficulties or maybe some behaviors increased after their intake. So just because it wasn't recommended, we can absolutely still look at that as an appropriate level of care. All right, moving along. I had a lot of time slotted for all this stuff, and I think we're flying through it. So, and if anything comes up later, feel free to let me know. I'll send my contact information in the chat. So the SED waiver, the serious emotional disturbance home and community-based services waiver, SED waiver, it provides services that are enhancements or additions to Medicaid. So what this means is it's kind of extra or additional amounts of services that are typically under Medicaid. There are additional services that would not, we could not provide to the child if they're not on the SED waiver. And I'll go through what those are. So this is for children up to age 21. The caveat to that, we have to apply for the waiver prior to the youth being 18. They can stay on it up until 21 if they continue to qualify for that waiver each year, which we do have to go through that recertification process on an annual basis. So this is a waiver out of MDHHS, and CMHs are tasked with operating the services. So here's some eligibility. criteria for SED waiver. So since we are using Michigans, this is a recommendation that comes from that. So as part of our application process for the waiver, we do have to show that the Michigans is recommending that level of care. At this point, we are still using a CAFIS and PECFIS, which is a tool that CMHs have used for a very long time. And that provides a score based on the youth's behaviors in all of the areas. So school, home, the community, substance use issues, any self-harm. At this point, we are using both tools until next year, when the focus will just be on the Michigans. Again, the youth has to be under the age of 18, but they can stay on the waiver until 21 if they continue to meet the eligibility criteria. And we also look at if the youth meets the state hospital criteria as defined in the Michigan Medicaid Provider Manual. So what that looks at is their overall functioning in terms of there's a wide range. I won't go through it all, but in terms of like suicidality, self-harm, any medication management that may need to be looked at, health and safety issues, kind of that like critical level of care. Typically, if the Michigans is recommending the SED waiver, they're also meeting that state hospital criteria on paper because we're looking at some of the similar areas. Additionally, for the SED waiver eligibility, the youth must live in a home or community-based setting, meaning that they cannot be residing in a residential or juvenile detention facility at the time that we're applying for that waiver. So they can't be in a child caring institute. Once that youth, let's say that you are working with a youth that is discharging from one of those settings into the community, we can apply, we can get ready for the application, but we cannot submit it until that youth is back in the community. We're looking at that idea of the functional impairment. So the youth has serious functional limitations that impairs their ability to function in the community. Again, all things that are noted within the Michigans and our CAFIS assessment. And this is a big one that sometimes gets overlooked. As part of the requirement for a youth to remain on the SED waiver, the family has to agree and commit to participating in at least one waiver service per month. And we'll go through what those are. So really part of this, they're getting that enhanced Medicaid. They're accessing services that, if this is a family with private insurance, they may not have had access to, or maybe it's a youth that already has Medicaid, but we need additional services. We really want them to benefit from this by participating in these services. So that is part of that, that they need to at least be in one waiver service each month. Another thing I just want to mention too, if a youth is on the SED waiver and things improve, which is absolutely our goal, that youth can remain on that waiver and receive those services for that full year. So it's based on when we apply, they have 1 year. So even as things get better and maybe, their scores decrease and things are going great, that does not make them ineligible for that waiver prior to the annual. So just something to keep in mind too. At any point, a family can choose to end waiver services. They can disenroll from that at any point throughout that year. We typically work with families a few months before that annual to go over eligibility and just see where they're at. So there's no surprises if that youth does not meet eligibility at that annual. Any questions at this point? Okay. So here is our list of services that the SED waiver covers. So keep in mind, most of these services are covered under Medicaid. This is that enhanced rate. And if you do at any point want information about, how many authorizations for each of these, let us know. It is provided in the Medicaid manual, but it's a good jillion pages. So if you want a snippet, we can absolutely send that to you. So under SED waiver, we're looking at services like Respite, community living supports, or CLS, family home care training, family support and training, home care training, non-family. So what the heck are these? So Respite and CLS, I believe, are being discussed today. If not, they will. I see Liz nodding. So yes, I won't go into those too much. Family home care training and family support. Really, these programs are looking at additional trainings that can come in to work with caregivers. Some of the services that we have right now would be like autism staff meeting with caregivers and kind of prepping them for what autism therapy is going to look like, providing family skills training. In terms of the home care training non-family, what that allows us to do is authorize training from a master's level staff to train the additional staff in the home, like a CLS worker or respite worker. So we can go in, that might be anything from, the autism supervisor or staff working with the family, maybe the occupational therapist is providing some education and training to the CLS worker that's working with the youth. So that's what that non-family means. Basically, we're training the staff that are working with the family. Child therapeutic family care, that's the new name. You may have heard of the therapeutic foster care. So that is now being referred to as family care. That is a covered service under the SED waiver as well, in which the youth would be in a therapeutic foster home. And we're still working with the entire family. So this may be a youth in the foster home setting, but we're working on behaviors, working on parent training with the goal of reunification back to that family. And that is not something that's set up, through DHHS. So it's not a court case. That's something that's specific to, this is a therapeutic environment. Therapeutic overnight camp. This is providing funding for up to 3 camps a year for a youth to be able to go to, whether that's a specialty camp specific to, behaviors. We've had youth that go to Eagle Village or maybe a YMCA camp where they're working on, social skills, how to interact with other people. The budget for that allows also to look at funding for if additional staffing is needed for that youth. Maybe, hiring another counselor that's in the cabin for that youth. And I believe that's $1,400 per session that we can use for that. Overnight health and safety is another area that's covered in this. This is a little bit of I don't want to say touchy subject because that sounds bad, but sometimes confusing under the SED waiver. So overnight health and safety is a program that really is, or not program, but funding to allow support in the non-awake hours. Here's the caveat to that. With the SED waiver, a lot of questions that we get related to this authorization is for youth that have those extreme behaviors. Are up all night, or, the caregiver is saying I can't sleep because, they're getting into things or there's a risk of harm. The overnight health and safety aspect is more specifically related to health issues and teaching and training that youth to kind of complete tasks that might be needed in order to help them live independently. And that's how it's worded in the Medicaid manual. So it actually does go over some things that it's not approved for youth with aggressive behaviors. It's not approved for situations in which the parent or caregiver should be doing that task. It's not specific to things like sleep apnea or I think it mentions even like diabetes or something like that, maintenance care, but specific to more of that like teaching and allowing that youth to learn how to move towards independence. So if anyone has questions after this, I'm happy to pull up the part of the Medicaid manual that goes over it a little bit more, but this is an area we get questions on a lot. The therapeutic activities are another area of the SED waiver that are not covered under traditional Medicaid. So these are specific to SED waiver. The therapeutic activities refer to music therapy, art therapy, recreation therapy, and just recently, equine therapy was approved under this. As you may know, if you are in our areas, this is a great option that a lot of these are not covered or provided in our areas. So as a CMH, we are actively working on finding providers. I'm giving a plug. If any of you out there know of anyone that does music therapy or art therapy, please let us know. Within the Medicaid manual, there are the criteria for their credentials. We have contracted with a recreation therapy provider, a grounded therapy network that I believe is in all of our counties at this point. It's out of Isabella County, but they're staffing rec therapists to be able to work with these youth. And that is a home-based program at this point. So the rec therapist is going into the home, working with that child. And equine therapy is the new therapy that has been approved under that. We don't have a ton of information. I believe I do have the credentials for that, if anyone is interested in learning more about that.
We don't even have the codes yet, right, Steph, for equine therapy? Because it just got added this year. The state
This
hasn't
got
even,
added.
has the state
Yeah.
released the codes yet?
No, the last I saw was a proposal for the credentials that are a part of equine therapy. So kind of like what training would be required for that person to be able to provide. At this point, if there is a recreation therapist that provides kind of equine therapy under that, we can use the recreation therapy code. We don't have that in our area under rec therapy, but I think at least in our, I think Macasta Osceola areas, we do have I think maybe some ins for the equine therapy once we get that going. So
Someone
here's
asked,
my contact. Oh, go ahead.
oh, I'm sorry. Someone asked if we can send a link to the SED waiver Medicaid cover services. Yeah, we should be able to do that.
Absolutely.
We can snip out that chapter in the Medicaid provider manual.
Yep.
Someone earlier had a question about the new program offering overnight safety, CLS respite. Lori, is that relating to what Steph went over in the SED waiver?
Yes, she answered my question.
Okay.
Yay, good. I love that.
Did you discuss stuff? I had to sneak out for a second. Did you discuss how wraparound can be offered for folks that are, or for children that are in CCIs up to 180 days? Did you go over that part of wraparound?
Just mention that briefly, that we can start wraparound prior to a youth discharging from a CCI or an inpatient. So what that allows us to do is help coordinate services as that youth is transitioning back into the home or the community. So that wraparound or ICCW staff would really just kind of start, meeting with the family, coordinating with that placement setting, assisting in getting appointments set up, whether that's an intake appointment to get in the door. Really, we want to avoid any lapse in care. So this can allow us to, if the youth is on medications, we can look at scheduling the psychiatric appointment or coordinating with their primary care doctor. So the 180 days is what the state allows us to do. We fully encourage notice as much as possible. So if there's any, foster care staff that, maybe have a youth in that facility or a facility that is transitioning out, let us know, give us a call, and we can start that process. We will work with Liz and her assessment staff on, getting an assessment completed and then being able to coordinate services. Sometimes if it's over that 180 days, maybe the plan is for 30 days and then something happens and it's over that, there is some flexibility within that. So we will continue to monitor. The same thing if a youth is already open to services and then is, it's recommended they go into a residential setting. We still have that amount of time to still be able to monitor things as well. So our goal is, to keep eyes on, to continue to support the family, so that, everything's kind of set up when that child returns home.
One just stipulation of that is sometimes we get calls from DHS where they don't have an established home yet in our communities, and they're asking for us to open up Wraparound. We can't really open up Wraparound because Wraparound is pulling in providers within our community, and so we want to make sure that that child is actually returning into a home within our 6 counties, because then at the tables, providers that may not be serving that child once they get discharged from a residential, and so there has been calls where I've taken where I wish we could open, but we can't open unless there's an established like home in our 6 county area, either a foster care home, a pre-adoptive home, or they're returning to their parents. So that's why sometimes we might, recommend as soon as they find a placement, let us know, give us a call back, and we stay in touch until we kind of figure out what's going on with the youth. But that's the only time we've delayed one of those referrals in the past, is because there hasn't been an identified home yet.
And it just made me think, Liz, when you said delayed. So one of the, pain points that we all deal with services is finding providers. So even though these services are, provided under the SCD waiver, we might still be actively working on finding a provider or a staff for that. We do have a process internally that we, provide notice to that family. They have, information on how to file a complaint or, a recipient rights if they feel like, things are too delayed. But the state does allow us to essentially authorize that service as we are working on finding a provider. So an example might be, we're talking about getting CLS, but we might need, a kind of a specific schedule based on the family. So we're working with providers and finding a CLS worker that can meet that need. That might be a delay in services, so we provide notice to that. So I know that that is a pain point for everyone involved. Any other questions or thoughts? Okay. Well, I got done early, so maybe that means you guys get a little break.
Thank you, Stephanie, so much. And I just want to, I'm going to take whoever's PowerPoint is willing to share, and I'll send it to this group along with the Medicaid provider manual snippet, probably sometime next week, but I'll include all that stuff in the email. And then hopefully by then, I'll also include the link to this training so that other staff can use it if they weren't able to attend today. I'm checking with the next 2 speakers to see if they're able to pop in early. If not, we might just have a quick break so everyone can go to the bathroom and whatnot.
Liz, do you mind if I introduce myself?
Go ahead.
For some people that that we haven't maybe had the chance to meet before, my name's Jolene Jernigan. I'm the family and child coordinator with Community Mental Health. I know there's a lot of familiar names here, and we've had a lot of email contacts back and forth, opening up kids into services and working together to get families started with services. So I just wanted to introduce myself and say good morning.
Do you want to put, Jolene, do you want
Nice.
to put your cell phone in the message too?
Sure.
Jolene is kind of the go-to for any families that might struggle with like entering our services, because we know getting into CMH services is a lot of steps. We wish it was a lot easier process and it was quicker for our families. And so Jolene has been amazing trying to coordinate with foster parents, with bio parents, getting the paperwork, doing all those initial steps to get people in super quick. And it's been awesome to be able to, we got a grant and we're able to hire that position. And it's been awesome to have her, because we know in the past, sometimes we lose families in the process flow, and we hate to do that. And since Jillian started, we've been able to get kids and families in a lot quicker into services, which has been awesome.
And I support the comments in the chat. Jolene is the best. It's been a wonderful addition to be able to have Joe help us with some of these cases, including cases that are coming from other counties that maybe are coming into our catchment under SED waiver or in foster care.
It could definitely be intimidating and overwhelming to get started with services. So anything that we can do to minimize some of that for families is definitely needed.
Well, thank you so much, Steph. I appreciate you popping in today and sharing your
Thank you,
expertise.
guys.
And she truly is
Have a
the
great day.
subject matter expert, even though she says she's not, but she is definitely the lead for SED waiver. If you guys ever have any questions, she knows her stuff, and she can help kind of that, answer any of those things, along with home base and actually any of our children's services. She'd be helpful too. And I'll include her information in the email also. So in case you guys have questions after today, you guys can get a hold of those supervisors next week or the following week. And I think Ashley is going to be able to pop in. I'm just checking really quick. So hold on one second. And if not, we'll do a quick break.
Morning.
Hey, Ashley, thanks so much for popping in early. Ashley is
No
our
problem.
MST multi-systemic therapist or therapy supervisor, and that program right now is offered in our Midland and Isabella counties. In the past, we tried to get it in our other counties, but we weren't able to hire the staffing from Acosta Osceola and some of our other Gladwin and Claire. And so right now we only offer it again in Midland and Isabella, but it's a great program. And thanks for coming in, Ashley.
Yeah, I have a PowerPoint if that's okay.
Yep.
Maybe. Oh,
Yep. It's on.
is it? Okay.
Yeah. You popped the second.
Okay.
Yeah, there we go.
Is there a way to do like presenter mode when you're on this?
You should be able to. I don't know. We can see her full slide though.
I know I can't see like my notes though, you know?
Oh, let me look and see if there's. I don't know.
Oh, wait. Can you see what can you see now?
I can just see your slide.
Oh, perfect. Okay. I got it. Okay. Well, good morning, everyone. I'm Ashley Thering, as Liz said, and I am the supervisor of MST in Midland and Isabella. Multi-systemic therapy is an evidence-based program, and our goal is to keep at-risk youth home with their families. So what MST therapy is, for our traditional model, I'm going to talk about a couple different adaptations to the traditional model. But for the traditional model, it's community-based for antisocial delinquent youth. And what we do, it's very systems based. So working with the youth in their natural environment, but looking at them for their entire ecology. So they're basically 5 different systems. So the individual, their family, the school, peers, and the community is what we would be considering the MST client as. MST therapists coordinate regularly with stakeholders. So that's really who the key participants are within the case. Usually that would be probation, schools, anyone else involved in the courts, maybe DHHS. Sometimes it's the advocacy center. Really anyone that the family would identify as a key stakeholder. When it comes to the traditional model, the qualifications for that model, the age requirements are 12 to 17. Court does not need to be involved. The youth is usually at risk of out of home placement. If uh if the court's involved, I guess. But as I said, the court does not have to be involved. But there are like antisocial delinquent behaviors present. And they can have comorbid psychiatric illness, but the primary reason for referral needs to be some sort of antisocial delinquent behavior. So like the running away, truancy, aggression, those oppositional, defiant behaviors. We really look at those youth and school characteristics. So say they're being expelled or dropped out of a formal education, or they're already attending an alternative school setting. They're having multiple suspensions for problematic behavior. They have high association with antisocial school peers, low affiliation with pro-socials, or just overall academic problems, risk of failure. We also look at youth behavioral characteristics, so crimes against property, drug abuse or dependence, evidence of drug use, just normal status offending, so like a curfew. Crimes against people, so robbery or theft. Also just the nonviolent aggressive behaviors. And then we also there's some just youth peer characteristics, so like gang affiliation, or I think I already mentioned the antisocial peer affiliation. So that's some of the specific referral behaviors that we would see for the traditional model. So the next model I'm going to talk about is the model for problem sexual behavior. So this is an adaptation of MST, and this is designed to treat youth with problematic sexual behavior. So this is a treatment that addresses youth that are showing signs of aggressive or non-aggressive sexual behavior. So this can include sexual assault or rape, watching pornography, masturbating in public, exposing themselves in public, really anything that would be considered a problematic sexual behavior. With this model, our main focus is really ensuring client, victim, and community safety. And we are always putting a strong focus on our PSB safety plans, and sometimes we are having multiple safety plans in place. So that could be an in-home safety plan, a community safety plan, a school safety plan. We've had several youth involved in sports, and so like really looking at making sure that youth are being protected when and that's not only the uh other youth in the schools or in the locker room, but also the client, and when they're using the locker rooms and stuff like that, or in the school setting. So always reviewing safety plans at every session and editing them as needed. And obviously, the qualification for that is that they've had to have engaged in a sexual behavior that's illegal, regardless of if they've been adjudicated or not. The age for this model is 10 to 17, so it is a little bit younger than the traditional model. The newest model that we have is for risky sexual behavior, and this one just started about 2 years ago now for us, and it's because we've seen such an increase in sex trafficking and we and just the risky sexual behaviors in general. So what this one focuses on is those youth that are, say, transmitting nudes or sexual content, ongoing involvement with older peers or adults, potential sextortion or high potential of becoming involved in sex trafficking. Parents have really put stuff in place, but the kids are going against those cultural norms and really pushing those boundaries. So this is something when MST, RSB, or the MST team can step in to assist. This is also for ages 10 to 17, and another obvious qualification is when a young person would be making themselves vulnerable through a variety of sexual behaviors. So there are exclusionary criteria for MST, and these are for all the models. So youth cannot be living independently. There has to be a caregiver identified. This can be a grandparent. We've worked with several grandparents. We have worked with foster families as well, but it has to be like a permanent placement. There's no plans of reunification. It can be like like a brother, an older sister, but they have to be like a permanent plan to stay there. No plans of like moving and going back home with a parent. So that is one of the exclusionary criteria. We would never take a youth that is actively suicidal, homicidal, or psychotic. It can't just be specific referral for psychiatric concerns. So we don't take anyone that is just like having symptoms of depression. There has to be that antisocial or delinquent behavior present. So we will take someone, say, that has like there's self-harm and they're also breaking into cars and stealing stuff from the store. Like there's a combination, but we would never take one that is just specific to at being actively suicidal. And then we do not the other one is youth with moderate to severe difficulties with social communication or social interaction and repetitive behaviors. So autism spectrum disorder at levels 2 or 3. We do work with youth with autism spectrum disorder at level 1. And usually I will read evaluations and determine what is appropriate based off the evaluation. And we just haven't seen a lot of success if we take someone with an autism spectrum disorder diagnosis at a level 2 or 3. And then additional exclusionary criteria, and this one's specific to the MST-PSB model. The caregiver has to recognize that the possibility that the youth committed the sexual offense. So if there is a parent that is in denial that the sexual offense occurred, then that is a barrier to treatment, and we are unable to move forward with treatment. We have had cases in the past that have not been successful due to this, and if there is no possibility that they believe that the youth committed the sexual offense, then we are not able to move forward with treatment. So what does an MST therapist do? I just put this on here because it really shows like all the different things that an MST therapist can do. I like to think of it as like a built-in suite of services. You can do a lot for like no additional costs. A lot of people will like refer out for different things, but when it comes to MST, you can do like your case management, your couples therapy, your substance abuse therapy, all in one treatment. So this is a good way to look at that. This is just to talk about how traditional MST is implemented. Overall, it's a very flexible model or treatment, I guess I should say, for the families, but also very intensive for the families. So it is only 3 to 5 months long, and so because of the short time frame, it is more intensive. And so there are 3 sessions a week, meaning 3 hours of face-to-face contact, and that is held in the home or in the community. And there is 24/7 on-call available for families that is specific to the MST team. So they would only be calling someone that is on the MST team, and there's only 5 of us. So they would be getting someone that knows their case and knows what is going on. So it's not the same as like the typical CMIT crisis number that they would be calling for all 6 counties at CMH. And I kind of already mentioned, but the traditional model is only 3 to 5 months long. The therapists have a small caseload, and that allows them to keep a very flexible schedule and really work with the families on when like when they're available. So whether they have a job and they have to schedule in the evenings or whatever that looks like for them, having only 4 to 5 cases or families at a time really allows for that flexibility. And then for MST, PSB, and RSB, really the only difference when it comes to like how this one is implemented is we do a lot of sequencing and clarification work with the family, and I'm not gonna dive deep into that because that's a whole nother training, but really the goal is to focus on like reducing that denial that might be present for the youth or the parent, and just promoting the appropriate friendships and general relationships in the youth's life and what those sexual experiences might look like moving forward, modifying the individual's social perspective taking skills, their belief system that potentially was probably skewed prior, and then just overall attitudes contributed to the sexual offending. And then for this model, again, it's 3 sessions a week. And sometimes when it comes to the PSB and RSB cases, we will meet more frequently at the beginning of treatment because of those safety plans and needing to get those in place. Because oftentimes for PSB cases, the victim and the perpetrator are in the same home. And so we will need to get safety plans in place immediately so that there is some form of safety for those victims. And that would obviously be our primary focus. And so we have to increase those sessions and frequency. As before, 24/7 on call. And then for this treatment, it is 5 to 7 months, so a little bit longer than the traditional program. Here's just a little bit of what our interventions aim to do. So obviously we want to keep the youth out of placement and just reducing aggressive and criminal behaviors, reducing substance use, any mental illness symptoms. We want to keep kids in school, and really improving a lot of the communication and pro-social involvement. That seems to be a big one that if we can get kids into pro-socials, a lot of things seem to start falling into place. I'm going to talk a little briefly about just the MST being evidence-based and overall model adherence. So when it comes to MST, it's very strongly like supervisor and consultant support. So when I talk about consultant, we have a consultant that is out of Chicago now. But he is available to us at all times for consultation on our cases. But in MST, we meet every single week for 3 hours, and we discuss every one of our cases, and I provide feedback as the supervisor on every single one of the cases. And the therapists submit a weekly update, basically like a individual plan of service every single week on every case, and feedback and goals are developed every single week. And that's what we do is during our supervision and our consultation. So our consultant meets with us for the last hour of that supervision. We also have ongoing quarterly booster trainings where our consultant will come in to Michigan and meet with us to just go like we have trainings on like things that are trending or areas of need for our therapists. We do TAM, SAM, and CAN collections. So those are adherence measures for like the therapist, supervisor, and consultant, making sure that we're all adhering to the model. So the families complete those surveys, supervisors and therapists. We do clinical development plans to just stay up and meet our strengths or meet the needs in areas that we need to improve on. And then overall, we have 9 principles that we try to follow that are the foundation of MST. And then finally, who can make referrals? Basically anyone. I just have a list here of ones that we have had referrals from in the past. But there's no reason for anyone not to make a referral, or that we wouldn't be able to accept a referral from. A big thing that I get asked all the time is, does the youth have to be in the court system? And they do not. So referrals can always be sent to me, or just even if questions that anyone had, you can always just email me about a youth. I'm happy to talk to anyone about that, if you just have any questions at all. But finally, if anyone has any questions, I'm happy to answer them.
Does not look like there's any questions in the chat.
Okay.
Thank you so much for popping in early today. I appreciate it, Ashley.
Yep, no problem.
Have a great day.
You too. Bye.
All right. The next speaker is Renee. She's our infant mental health and baby court supervisor, and she provides supervision across our counties, along with coordinating with some of the supervisors in the counties too. And she's going to talk a little bit about infant mental health and baby court today.
Thanks, Liz. I'm Renee Dyer. I am the infant mental health supervisor. I supervise all of our infant and early childhood mental health services across our 6 counties. Let me just pull up my PowerPoint here. Sorry, technology is not my friend today.
No worries. Mary earlier had a thing, kept saying it was going to shut down her computer. So,
Oh my goodness.
yeah.
All right, so we have infant mental health available across our agency, across our counties. So I'm the supervisor. In Isabella County, we have Megan, and she is an infant mental health case manager. For Mecosta County, we have Amy. She's an infant mental health therapist. In Clare County, we have Bridget. In Midland, we have Jasmine, Morgan, and Tara. Gladwin County, we have Janice. I have 2 interns, Megan and Kat are both MSW interns under the infant mental health program. And then Kim is an early childhood mental health consultant covering Isabella, Mecosta, and Osceola. And Janice is the infant mental health consultant that covers Clare and Gladwin, because she is a 0.5 infant mental health therapist for Gladwin County. So we have a number of infant and early childhood mental health services that we offer. Our services are relationship based. So we have infant mental health, we have baby court, and we have infant and early childhood mental health consultation. Those all fall under our early childhood mental health services. Our infant mental health service is a minimum of 4 hours per month, and we offer that service in the home and the community. Sometimes we will meet families at doctor's appointments, sometimes at story time. There are times where we will meet with families in the office, although that's not too often. The preference is really to be in their natural environment, in their home, where families feel the most comfortable and where we can really see family dynamics. The services that we provide include all of the family members and caregivers. So the people that are living in the home, that are in the day-to-day lives of the young child, that's who we want to work with. We're working on increasing stability for everyone. So within infant mental health, we provide therapy and we provide case management all in one. And the focus is really trying to increase that stability through helping parents or caregivers understand the developmental needs of their child, their social emotional needs, their physical needs, just to increase their development, reach those milestones on time. And then we're also working on improving attachment dynamics and parental capacities. We're really focused on the needs of the baby, so building that healthy and secure attachment so baby has that safe base to go back to, freedom to explore their world in a safe way. We're working on all of those developmental milestones, so trying to increase social development, emotional development, physical development. We're doing assessments to kind of monitor those things, suggesting activities to help support growth in those areas, while also trying to enhance the nurturing environment. So providing knowledge and like safety protection, we're helping parents be present and available. So we might be teaching some mindfulness skills or grounding skills just to help parents be in the moment with their baby, providing them stimulation. So different activities for different ages, helping them understand what's appropriate, what might not be appropriate for their infant, toddler, preschooler. And then also increasing that stability, consistency, and predictability. So helping the parent be available and stable for their child. We also want to help that primary caregiver with anything that they might have going on so they can be more available. So we're doing that therapy individually with parents often to help them address anxiety, depression. It could be postpartum depression, postpartum psychosis. We help support any of the caregivers with their needs that they have in mental health. The role of an infant mental health therapist, we wear a lot of different hats. So we are the voice of the baby primarily. We're trying to support the relationships across multiple environments. So when an infant is in foster care, we really want to provide those services not only to the parents, but also to the foster parents, understanding that that child is in both of those environments with those people, and to help create that consistency and stability in both of those places with all of those people. We provide education, so it could be parenting education, also assessment. We do a lot of assessments, developmental assessments, attachment type assessments. We're also able to do parenting assessments. So we're just doing a lot of different types of assessments. Some of them include observation, some of them are like paper forms, but a lot of different, like taking information in to decide the course of action and help that planning moving forward. Often we provide report or testimony to the court, especially in the case of baby court, which I'll talk about in a little bit. We're also in an advocacy role. So sometimes a parent will want something and they feel like others aren't listening to them. So we may come alongside them in a meeting, maybe at their primary healthcare office, and help advocate for something that they're looking for, or we may be advocating for additional assessment within like a preschool, but we're there as a support, as a therapist and a case manager. So in infant mental health and baby court, we provide a few different interventions. We have infant parent psychotherapy, so really looking at what that parent has experienced in their own upbringing, and is that something that they want to carry forward into their parenting of their child, or is that something that they want to leave behind? So we really dive into that. We call it like the angels in the nursery, like who are their protective people when they were growing up? Are those people that they can pull forward? And kind of looking at who and what supports they have now as they're raising their own child. We do infant parent observations. So again, looking at that attachment, the quality of it, how can we support building attachment if it's not there, or strengthening attachment that is already there? We're assessing for parental capacities. So looking, can someone parent this child in a healthy and safe way? Do we need to build certain capacities or strengthen others? We provide developmental guidance. So again, like here's some activities that you can use to help encourage your child's problem solving or social emotional development. We're there for that emotional support and empathy, that advocacy role, and then also the concrete assistance for case management. So if a family is looking for housing, they want to apply for employment, they need help filling out different applications, we can provide any of that as well. And then we all attend reflective supervision. So reflective supervision is a little bit different than clinical supervision. It's really looking at how the cases that we work with in infant mental health impact us, because we're working with a very vulnerable population. And so it can be heavy at times. And so we take kind of an internal glance at how working with these intense cases and being that voice for the baby when often people are not ready to hear that baby's voice impacts us as clinicians. So we have Baby Court in Clare, Gladwin, Isabella, and Midland counties. And this is a collaboration between DHHS, the court, and CMH. The referral comes from DHHS upon the removal of a child that's under the age of 4. And we support permanency through intensive services at an expedited rate. There's a few different components that are included in Baby Court. We provide supported parenting time. So that's a little bit different than a parenting visit. It is with the clinician playing an active part in that parenting time. So it might be reflecting on how the child is looking at the adult, helping them look at what the baby's trying to say. Oftentimes we'll speak for the baby, which the first time that happens kind of throws parents off a little bit when we're speaking for their child, but eventually, like, it does help them read their baby's cues. So it's can be pretty influential to helping parents move forward in parenting more actively. We also offer individual and therapy services as well as case management. We have monthly family team meetings for Baby Court with DHHS. And then we have quarterly or 45-day court hearings, depending on the county that Baby Court's in. We have a partnership for substance use services. Sometimes it's with 1016, sometimes with J&A, depending on the family and their preference as well. We offer the Nurturing Parenting Program. So that is a parenting group that I'm going to also talk about in a little bit as part of Baby Court. So parents get that parenting education. We have bi-monthly or quarterly Baby Court Steering Team Committee. Again, that's based on the county that we are providing Baby Court in. And then we also support the foster parents. So we want to make sure that the foster parents that are caring for these children that are a part of Baby Court are getting support as well. So my personal preference when I have a Baby Court case is to meet weekly with the foster parents, just like I'm meeting weekly with the bio parents. And then we have monthly DHHS and CMH meetings where we're talking about those cases and revisiting what are barriers to reunification and how can we overcome those barriers, and how can we come together as a team and support the family as they move towards reunification. So then we have infant and early childhood mental health consultation. And so this service is newer. We'll have it in all 6 counties starting October 1st. Right now we have it everywhere except Midland. So what this is this supports social emotional development and behavioral health for young children in their licensed daycare or preschool setting. So this is not a direct service. This service is consultation to the provider. So it's providing, the services are to like the preschool teachers or the daycare providers to support them with how to best help a child that's in their center. So it's not a direct service with the child. It's prevention focused. We try to get 24 encounters in 3 months. And the child does not have to be open to CMH services to have this. They can be, and we have a way to go about that, a referral internally, but they don't have to be open to CMH. So if a child is really struggling out in the community in a certain daycare setting, we can go into that daycare and we can do a child focused case where we're just focusing on supporting the center with how to best support that child. If an entire classroom struggling, we can support that classroom with maybe some ideas of some additional education they could add to their curriculum that's social emotionally focused, or maybe it's rearranging the room in a specific way to make it safer so there's not hiding places for kids, or it seems more open and they have safe spaces to go to if they need. Or we can do an entire programmatic focused case, and that's how helping the entire program. So we have different levels of support we can offer for that. We have two parenting groups. One is the Nurturing Parenting Program. That's a 16-week evidence-based group. We have different versions that we can run of this. My favorite is the parents that are in treatment or recovery for substance use and mental illness. That's my favorite group to run. But we do have infants, toddlers, and preschoolers as a curriculum. We have teen parent curriculum. We have a prenatal curriculum. So there's a lot of different curriculums that we can run as the Nurturing Parenting Program, kind of depending on what the need is that we're seeing at the time. So the philosophy of Nurturing Parenting is nonviolent, so it's a hands-off approach to parenting, and that's why we adopted this program as the one that we use at CMH. It really focuses on empathy, helping parents build their own self-worth and self-esteem, and helping them encourage positive self-esteem growth within their children, empowering their children to be independent and build their autonomy when it's appropriate for their age. Discipline through guiding behavior. So again, that hands-off approach, we're using like removal of privileges, or like if you break something, like maybe you're doing chores to earn money to buy that thing to replace it. So we're really doing positive approaches when we're talking about discipline in that group. Talking about appropriate family roles, age appropriate expectations. We do a little on child development so people understand what age appropriate expectations are when they're in group. And the underlying focus is really on nurturing and attachment. So how can you nurture your children while also nurturing yourself? And then we have trauma-informed parenting, and this is an 8-week group, and it's facilitated by one clinician and one parent with lived experience. So that parent has also raised a child that has experienced trauma. So that's what's really unique about this group, and that's the requirement for this group, is that there has to be that parent with lived experience. The focus is on supporting a child that's experienced trauma. And at some points, it may be parents that they were a part of the trauma that their child has experienced. For other parents, it may be like foster parents that are caring for a child that's experienced trauma. So it's a mixed group. A lot of times we have people from, it could be grandparents, a lot of different people in those groups, but it's very focused on the how. How do you care for a child that's experienced trauma when you flip down your trauma lens and things look a little different? And we really focus on self-care, so care for the caregiver. How do you take care of yourself? How do you address your own trauma so you can be present and available and not letting your own trauma impact your child that's experienced trauma as well? So those are the groups that we offer that are parenting groups. And then if you have any questions, I have my email up here. It's rdyer@cmhcm.org.
Someone had a question in the chat. When foster youth are referred to infant mental health, do you work with both the bio parent and the foster parent, or how does that work?
Yes, that would be the preference. The only time we wouldn't is if we offered to meet with the foster parent and the foster parent declined.
For the trauma-informed parenting, that's only for kiddos that are 0 to 4, or is it for older kids as well too?
That one's for older kids as well. And
Oh,
so is
cool.
nurturing parenting doesn't have to be just for 0 to 4 either.
Okay, cool.
Both of the
Good to know.
parenting groups. Yep, they're open to any age.
One of the things that me, Renee, and Jolene kind of talked about were some of these infant mental health referrals, and how Renee and her team really like to get the bio parent involved from the very beginning. Because if, because if you don't, then sometimes you lose that engagement with the bio parents if you're only like involving the foster parent in services. And so I think Renee and her team do a really good job trying to coordinate with both. Even when it's tough, even when sometimes the parents have like a no contact order, or sometimes they might not be answering calls and stuff, the team definitely tries to connect from the very beginning to try to engage them, which I think is really good. Any other infant mental health questions or baby court questions? Angela is the supervisor of, well, she's the manager of utilization management, and she kind of provides oversight to staff that ensure that we're providing necessary services. They look at medical necessity, ensuring that people are getting services and not getting underutilization or overutilization of services, and also kind of looks at the Medicaid provider manual to make sure that we're providing appropriate services based on kind of the rules of what we can provide to certain populations. Today, she's going to talk a little bit about CLS and respite. And there's another question that I just thought of, Angela, that sometimes DHS reaches out to us when someone's around like 18 years old to look at AFC placement. So I wondered if you could kind of share a little bit about how we determine like if someone's eligible for AFC. Also, if you can kind of, because that's another question that we get a lot from DHS staff, but thank you for coming today.
Yeah. All right, let me share. Now, once I share, I won't be able to see anybody. So just if you have questions, just jump on in. And Liz, if you could watch the chat for me, because I'm not good at watching the chat and doing the presentation at the same time, just being honest here. Can everybody see my CLS?
Yes.
You guys see that? Okay. So, like Liz said, I'm Angela Zywicki. I'm the utilization manager here at Community Mental Health, and I'm going to be talking about CLS and respite services. So again, if you have any questions, just feel free to ask them. So our agenda for today will be to review the following: an overview of CLS, CLS reminders, overview of respite, Medicaid provider manual, respite definitions, respite reminders, medical necessity, and we're going to talk a little bit about medical necessity discussion topics. So here's our overview of CLS. So per the Medicaid provider manual, community living supports, CLS, are used to increase or maintain personal self-sufficiency, facilitating a beneficiary's achievement of their goals or community inclusion and participation, independence, or productivity. The supports may be provided in the beneficiary's residence or in community settings, including but not limited to libraries, city pools, camps, etc. So they also drill down a little bit. So for CLS provides supports to beneficiary younger than 18 and the family in the care of their child, while facilitating the beneficiary's independence and integration into the community. The service provides skill development related to activities of daily living, such as bathing, eating, dressing, personal hygiene, household chores, and safety skills, and skill development to achieve or maintain mobility, sensory motor, communication, socialization, and relationship building skills, and participation in leisure and community activities. These supports may be provided directly to or on behalf of the beneficiary. These supports may serve to reinforce skills or lessons taught in school, therapy, or other settings. For beneficiaries up to age 26 who are enrolled in school, CLS services are not intended to supplant services provided in school or other settings. I know that's a lot. Does anybody have any questions? I'm also going to share, I'll share my PowerPoint with Liz so that you can have a copy of it. Because I know a lot of this is just Medicaid provider manual speak, and so sometimes it's good to refer back to it. But any questions? I always pause for a couple seconds just so that you can unmute, because I know sometimes it's hard to unmute. All right, let's keep going. All right, so here are some CLS reminders. So purpose of CLS is to focus on teaching and training a measurable skill. The skill that is being taught needs to be age appropriate. And this is a big one because sometimes people will ask for CLS for kiddos that it just doesn't even make sense. So you wouldn't expect a young child to be out in the community alone if it's not age appropriate. So you also wouldn't expect a young child to work on learning how to wash laundry as it's not age appropriate. So those are sometimes the things that come up. Well, they need help with laundry, but if it's not age appropriate, it wouldn't be something we would have them work on. And then CLS staff work on the skill with the consumer so they can learn the skill. So the other important piece is that this is doing with the person and not for the person. It is not appropriate for CLS to do all of the family's laundry and dishes, as their work needs to focus on the child. And I share some of these examples because they have happened. And then we have to go back and do retraining on what CLS is for. So CLS is a face-to-face service. So that means that the staff has to be with the kiddo or adult. And then just some research supports that children are able to generalize skills more effectively that are taught by their parents in their own natural environment. So sometimes we use CLS, but the true way for kids to learn and generalize skills the best is with their parents. If a consumer is living with family or natural supports, there is an expectation that natural supports will assist the consumer to provide supervision and care. So that's another piece that we always have to look at to help us figure out the medical necessity of a service. Add more CLS reminders. So if anybody has any questions or they're not sure what the intent is, please let me know. Okay, so this is a mouthful. CLS services may not supplant services otherwise available to the beneficiary through a local education agency under the Individuals with Disabilities Education Act or the Rehabilitation Act of 1973 or state plan services. So we're looking at personal care, assistance with activities of daily living in a certified specialized residential setting, home help assistance in the beneficiary's own home, unlicensed home with meal prep, laundry, routine household care, and maintenance activities of daily living and shopping. If such assistance appears to be needed, the beneficiary must request home help from MDHHS. Now, it's interesting because kiddos can get home help. And so sometimes even our local DHHS offices will say they can't because it used to be called adult home help. But there is criteria for kiddos to get it, and it's based on the kiddo and it's based on the parent and what they're able to do. So, and they make those decisions, but that is another avenue of support for families that you would want to consider.
Someone asked in the chat, does CMH still offer passes for places like the community center, Discovery Museum, etc.? And I just mentioned that typically for those type of services, we get donations from the community. And so, for instance, like in Midland, we have like a family pass that we get I think United Way donation to get that pass that families are able to use. There's only certain times. Can you kind of explain like certain situations where we might pay for like bus tickets or like an art class or something like that? That's not like does that make sense, Angela?
And there's camps that we can pay for if the person meets the eligibility. There's also transportation is involved with CLS, so you have to have the service though. So we only have certain services that we can provide transportation with, and one is CLS, one that I'm talking about right now. There's other ones, but they really wouldn't apply. Well, they would apply to older kids. If they're getting vocational services, we can use transportation. That's about it. I don't think there's not too many kiddos that are going to Clubhouse. Clubhouse is another one where we provide transportation too. And then there was a change in how the transportation is supposed to be billed. And so a lot of the transportation comes from the mental health plan now. So if someone's going to ABA, or if they're going to therapy, or if they're seeing the psychiatrist, like all of that goes through their mental health plan now. Does that answer all those questions?
Yeah, someone just asked for a list, and then they said, do we have a list for camps? And I said in the chat, I can send them, but typically for camps, it's family preference or individual preference. There are some camps out there, like Stephanie mentioned, like Eagle Village, Camp Fishtails, there's a YMCA camp, but typically it's like the families are the ones that kind of indicate what camp, they want their child to participate in. And then we just make sure that it's appropriate, that that we're looking at the appropriateness of us paying for that camp. But yeah, I can give you the list of ones that we typically use.
That is on our external CMHCM website too, the list of our providers, because we have to have a contract with the camp. It can't be any camp, just so that that's clear, because we did that in the past and the state said, no, you have to have a contract with them. They have to be a Medicaid provider. So there are things that we have to do, just so that if you're talking to families, you don't want to give them, if you tell them one thing and then we tell them another thing, and then they get confused and then they think one of us is telling them incorrect information. So it's always good to make sure that you have the right information. So if you ever have questions, make sure you're reaching out. Because I know none of us are intending to do that. It just happens sometimes. All right. CLS. Okay. Payment for CLS services may not be made directly or indirectly to responsible relatives, spouses, or parents of minor children, or guardians of the beneficiary receiving CLS. CLS is required to occur in the community or the individual's home and cannot occur in the CLS staff person's home. And the reason for that is because their home is not considered to be in the community, or it's not the consumer's home. So the intention is to generalize the skills in the community or in their home. To qualify for this service, the person has to have state approval for a waiver. So they have to either be on the HAB waiver, the SED waiver, the children's waiver, or the 1915 I-SPOT waiver. So we can't approve the service until they are on one of those waivers. The CLS request needs to meet medical necessity for the service to be authorized, and decisions about the method, skills, and amounts of CLS are decided during the person-centered planning process. Any other questions?
Sometimes we get requests from families due to physical aggression of a child, where a parent might want a break, or they might want someone to kind of intervene when someone's being physically aggressive. Can you talk a little bit about that in relation to CLS?
Right. So if there's an issue with behaviors, that's when they would have a behavioral assessment. Because I'm just going to be honest, CLS staff, they're not expected to have a degree. They're expected to be 18 or older. So we would need to have certain professionals involved to help make sure that the CLS staff are doing things that are correct, because they do have things that they have to follow. They can't hold someone. They can't, there has to be a behavior plan in place that's agreed upon by the parents. And so it just can't, it can't be something that they can just jump into, if that makes sense. All right, any other questions about CLS? And then I'm going to jump to Respite. Right. So the overview of respite. Per the Medicaid Provider Manual, respite care services are intended to assist in maintaining a goal of living in natural community home and are provided on a short-term intermittent basis to relieve the beneficiary's family or other primary caregivers from daily stress and care demands during times when they are providing unpaid care. So here's kind of a definition of those terms. So short-term means the respite service is provided during a limited period of time, a few hours, a few days, weekends, or for a vacation. Intermittent means the respite service does not occur regularly or continuously. The service stops and starts repeatedly or with a time period in between. So respite would not be something that would be provided on a weekly basis. Respite is something that would not be provided multiple times during the month. So it really is just a break during the month. Primary caregivers are typically the same people who provide at least some unpaid supports daily. So there has to be time where they're helping the kiddo and they're not paid for those services. So unpaid means that respite may only be provided during those portions of the day when no one is being paid to provide the care, not a time when the beneficiary is receiving a paid Medicaid state plan, home help, or waiver service, or CLS, or service through other programs like school. And then here's a little caveat. Beneficiaries who are living in a family foster care home may receive respite services. The only exclusion of receiving respite services in a family foster care home is when the beneficiary is receiving therapeutic foster care as a Medicaid SED waiver service, because that is considered in the bundle rate. And you can refer to that in the Medicaid Provider Manual. I have it listed in there how you can find that information. Any questions so far? So here are just some respite reminders. Respite is, again, a face-to-face service to a consumer for the purpose of providing temporary relief from the care of the consumer to the primary caregiver or foster family home. Respite staff are required to be awake. Respite cannot be billed when the provider is sleeping. Respite cannot be provided when a parent is working, as work would not be considered to be a break. Children living in foster care are not able to use the choice voucher arrangement, but they can receive services from a CMH contracted provider. And again, respite is not a weekly service. Respite is not meant to be provided for every requested break from caregiving. So you want to review the reasons for respite with the unpaid caregiver in order of identified importance. So what do you specifically want to be able to do, when, how often? Prioritize requests to ensure that the most important breaks are considered. A parent or guardian may not be considered a provider nor be reimbursed for this service. So again, to qualify for the service, the person has to have state approval for a waiver. So they either need to be on the HAB waiver, the SED waiver, the children's waiver, or the 1915 ISPA waiver. The respite request needs to meet medical necessity, and decisions about the methods and amounts of respite are decided during the person-centered planning process. So this is when you would also talk about camps, using respite for that purpose. Right. Any questions about respite?
Someone asked, can respite and CLS be provided by the same provider?
Yes. As long as so it depends on if they have the contract with us to provide both services, but we do have providers that provide both. Any other questions? And if you stump me, I will get back with you. So if you ask me a question I'm not able to answer, I'm more than happy to research it. All right, I was going to touch on medical necessity, but I know, Liz, you asked me about AFC, and I don't have that in front of me right now. Are we looking at criteria for foster, or well, you want adult foster care then and not child foster care, right?
Yeah, I think sometimes DHS will reach out to us because they have like a, like a 17, 18-year-old and they're trying to figure out next service. And a lot of times they're in like a residential setting. Some of the things that we've run across is that all of our AFC providers typically only provide services for like 18 and above. And so we have to get like the AFC home would have to get like a modification from their licensing to take anyone under 18, and it requires a lot of paperwork and a lot of where like a lot of times the AFC providers will say no because they have a lot of older people in their AFC homes, and putting someone 17 in there is just not a good fit. And so that's I just want to bring that up as one of the kind of barriers that we see when it's like a 17-year-old. For us, they have to be 18 and older for most of our AFC licenses. The other thing is I think that there's some confusion around how it's paid for. Like sometimes at that 17, 18, they don't have SSI or disability yet. And so that's another question that I usually get from workers, is that most AFC homes are paid for by their SSI or SSDI that pays like the room and board. And then when we look at paying for additional staffing, then it kind of goes back to that CLS. It has to be for a specific need. It has to be that CLS provider has to be in the home to provide assistance or training that person in order to become more independent. That's kind of the role, is we want people in the community and living in independent settings. And so there has to be a particular reason. So kind of like around that, Angela, if you have anything more to add, because sometimes people are confused about like funding and like when we're able to pay for an AMC home and when we're not. Does that make sense?
Yeah, and no, you're spot on, because technically we're not a child placing agency, so that gets really tricky too. So adults, we're good to go. But when it comes to children, that's where we have to have state approval. And you're correct. It's harder to get the SSI for the room and board. So there are lots of things that we run into that it makes it really difficult for us to do that. And so when they're looking at someone going into an adult foster care home, we have a whole list of, and I don't have it memorized, I'm sorry, but there's a whole list of things that they look at. Like, do they need help with eating and feeding? Do they need help with grooming? Do they need help with mobility? And then do they need help with medications? And so they have to have a need for those areas, right? So that's what makes them eligible for adult foster care home. It can't be that, or sometimes it's behaviors too. We see that a lot where there's some behavioral issues and they need support from staff we also look at staff that are in and out of the home, so that because if someone has a lot of high needs, it's good when you have staff that come in and out so that they're getting a break as well, so that the person is getting the best support and the best help that we can give them, and ensuring that they're safe. So we wouldn't put someone in just because we think they're not able to do stuff. We have to actually really drill down. Do they have that need or not? And that kind of falls into medical necessity. And we do have some, Liz, I can share with you, I'll ask April, but we do have some really good information about adult foster cares that I will make sure to give you, that you can share with this group too.
Someone also asked in the chat, what's the average number of hours used for both services each month? So how much, like if a child meets criteria for a respite and CLS? Is there an average amount that, because we got to remove schooling hours, like we can't provide that during schooling hours. So during the school week, is there an average amount that kids and or children kind of get authorized for either of those services or both of them?
So that's a great question. Here's my tough answer. Every case has to be looked at individually. So there's no good rubber stamp answer for any of this because we have to look at what supports, and that's what goes into medical necessity. We have to look at what are their natural and community supports able to provide. The services are not intended to supplant services provided in school and other settings. We have to ensure the Medicaid services are the services of last resort. We have to utilize evidence-based practices if available and appropriate. It's important that us and you as the workers at DHHS, that we kind of explain that to families so that they have an understanding of, we're a team and we want to make sure that they understand that we also have to follow the Medicaid provider manual for all services. So now I can tell you, we do have from our level of care grid, which we use now, that is just as a guide. It's not a definite, but we do look at respite depending on what services they're needing. It's around 15 hours a month, but that is just for like your average person. Now, when they're on the children's waiver, the SED waiver, that's a little different. So I don't really have an average. Young kiddos, usually CLS is not appropriate. It's not appropriate service. Respite is usually the most appropriate service. Yeah. All right, let me go to this next one. This is kind of how we figure out what supports are needed. So we look at these medical necessity discussion topics. Again, we are required to explore natural supports and community supports prior to exploring paid supports. So how do we do that? So we ask the family, who helps you in your life? We ask the consumer, who helps you in your life? Who helps provide you with support? Do you have family or friends that can help with giving you a break? So some people have a lot of support around them. So they really don't need the respite, the paid support of respite, because they have aunts, uncles, grandma, grandpa, sisters, that are like, yeah, no, we can provide you with a break. So then if that's the case, then we wouldn't even look at paid supports. We do look at also when we're trying to determine medical necessity, we do have to look at what other paid supports and services the person might be getting. Community supports do you have that might already provide a break from your providing care? We also look at that. Where are places you go, in the community, businesses, parks, faith-based communities, and healthcare facilities? Do you belong to any groups or membership organizations? So we have to explore local services too, and public resources that everyone uses. And so at our CMH, we also have on our internet, we make sure that we list out free resources that are in the public that people can access. And so we share those resources too, to make sure that, we're looking at those and using those appropriately before we're adding in paid supports. And not that we approve paid supports all the time, but we really have to dive in and look at what the need is. Hey, that was all I had. You guys had lots of great questions. Any other questions?
Julian also added the list of therapeutic camps in the chat. I'll also send that out via email too. But those are the camps that we're contracted with that families can look at.
Perfect. Perfect. So I will make sure that I get the AFC information, and I'll make sure that I share my PowerPoint. Who should I send that to? Should I send it to you, Liz, or should I send it to Jolene?
Yeah, you can send it to me. And then someone just asked a question. During my CPS investigations, I have an average of 3 families per month with children either diagnosed with autism or suspected autism. Is there a brochure we could provide to these families that could explain possible services and who to contact? Yep. Yeah, I can give you a brochure on our autism services, and kind of in the PowerPoint that Mary talked about this morning. I'll also send that out, and that kind of explains the process flow for autism services and what happens. Because we kind of have a deficit in providers, the autism evaluation, as you heard this morning, takes a little bit